Meg. Good afternoon, ladies and gentlemen, and welcome to the Annual Council of Governors and Members meeting for Warwickshire. This is the 11th Annual General Meeting we've had, and it's divided into three parts. The first part is the formal part of the Annual General Meeting. We've then got two presentations, which we're looking forward to from Vernon and from Glenn. And lastly, we've got some going the extra mile awards. But before we get into the formal business of this afternoon, I and the board and all of the governors are very conscious of the personal tragedies of people who have lived through COVID and have lost loved ones at our hospital and elsewhere. We're also very conscious of the quite extraordinary efforts of our frontline staff and all our support staff in terms of helping to ensure our patients and their families stay safe and that they themselves remain safe. And we're also very conscious of the enormous support from members of the public towards our staff. So on behalf of the Board of Directors and the Council of Governors, I just wanted to thank and put on record our appreciation of the personal nightmares and tragedies that some people have lived through, and an enormous thanks to members of our staff. So we'll start off with the formal business, and the first is the apologies for absence from governors and directors. We have apologies from Jean Arrowsmith as a governor, Michael Coker, Helen Darcy-Cope and Callie Harrison. And from board members, we have apologies from Helen Lancaster, Kim Lee and Anne Pope. We'll therefore move on to the formal bit of the business. And the first is the minutes of the 10th Annual Members Meeting from last year, which was held on the 8th of July 2019. That was when we were able to meet physically. Now we're obviously having to meet digitally, and we hope that you find this experience useful, and if you do want to ask any questions, please do so as the Annual General Meeting progresses, and I will try and answer as many of them as possible at the end of the meeting. But in terms of the last set of minutes, these have been approved electronically by the Council of Governors and the Board of Directors who attended it, with two amendments. The first was on page 4, minute 2019. 0.0702, which was adjusted to include clarification on what services from Rodder House were moving into the Stratford Hospital building. And there were some minor amendments to the present list and correction of minor typographical errors. So I am confirming that subject to those above amendments, the minutes can be approved. So we'll therefore move on to introduce our session on the annual report and quality report and the summary accounts and auditor's statement. So over to Glenn Burley, our Chief Executive. Glenn, over to you.
Okay, thank you, Russell. I'm hoping that I'll appear on screen any moment. What I'm going to do is share with you a presentation to take us through the annual report. So the background you would have seen on me before was taken before COVID. I'll make that clear. So what I'm going to go through with you is a summary which is available on our website of our annual report and accounts. And within our annual report is also our quality account. So if anyone wants to look through the detail, all of that is on the website. But if you want to look through the summary, that's obviously on the website too. Firstly, just to talk about the level of activity that we've undertaken. Obviously, at the end of the last financial year, we had the start of COVID, which did change the activity profiles of the NHS. But even with that, which started to hit us in February, March time, we still saw much more activity in the last financial year than we did in the previous. And you can see from this chart the levels of activity. So you add them all up, it's about 1.5 million contacts over the course of the year. So that's 4,000 every single day. And for us, obviously that is every single day. Our services remained open throughout COVID, but obviously throughout the entire year, 24/7. And our activity spans not only South Warwickshire, which is obviously our title, but also the whole of Warwickshire, our community services, and also now community children's services that go into Coventry and Solihull. Just to talk firstly about the main high point for me, which is the outstanding rating that we achieved, and that so the photograph you can see on that was taken pre-COVID. We were inspected during the course of the year, and we received our rating in December. We are the only trust in the Midlands to have an outstanding rating that has acute services, and only 1 of 10 in the country. But the other thing that is often overseen in all of this is, as well as the quality rating, we also had an outstanding rating for use of resources. So that is looking at the efficiency and productivity of our services. So it's a great achievement, and obviously it was first and foremost the achievement of our staff that we managed to get that rating. So we launched a Thanks a Million campaign, and we've been working with our staff to offer staff support to recognise their great achievements. It's also been a year where lots of exciting things have continued to go on across the organisation. So there's 2 things on this slide. Firstly, the upgrading of our Aylesford cancer unit at the Warwick site, which was supported by St Peter Rigby and the Rigby Foundation, as they did with the cancer unit that exists at Stratford. But also some great innovation around digital working, and we will soon be launching a digital hub at Stratford Hospital also. But we also look ahead to some other developments. So within the summary document, you will see the development that being planned at the moment for Ellen Badger Hospital in Shipston-on-Stour, which is to co-locate with community services and primary care into one site, which is a really exciting project for us. And then on the right of that picture, an artist's impression of the new car park that we're building to support patients and visitors, but also staff parking around the site and to make it easier for our neighbours. And then also a photograph there of our theatres, and one of our major capital projects over the course of this last year was an upgrade of our theatres on the Warwick site, which actually really helped us during the recovery from COVID. We should also turn to some of the national standards and targets. These have existed for a number of years now across the NHS. There's a national review underway to reset them. Generally across the NHS, they haven't been met, but generally we've met them as an organisation, but there was an impact on our performance at the end of last year. So I won't go through all of the detail, but one of them, the main standards, they're the 18-week referral to treatment target. We achieved that standard in the course of the year. Very few trusted. So the A&E standard, we achieved 89.1%. You can see on the chart there, actually that's one of the best in the NHS, and we continue to be one of the best in the NHS on A&E performance and flow. That is delivered not just by the services that we run on the acute site, but probably even more so by the community services that we run across Warwickshire. So the out-of-hospital teams help flow in and out of the hospital and help to deliver that. And then on the right-hand side there, some of the reductions in infection prevention, improvement there, and also cancer services. So our demand when it comes to cancer services has increased. We're very close to achieving those national standards and targets, as you can see. That demand has continued. And over the course of this year, we're actually setting out to significantly improve cancer performance. One of the main indicators, though, and if those of you who attended our annual general meetings over the years will have heard me talk about this before, is the annual staff survey. It's the biggest survey in the world of any workforce, and we always seek to do well in this, and we've done well again in the last year. In fact, the 3rd best in the country on the morale indicator across all trusts in the entire NHS. And as you can see on those scores on that chart, if you look at every single indicator compared to the national average, we were doing better as an organisation. And what this means is generally engaged staff and happy staff are delivering great service to our patients, and that correlates in lots of surveys that we have around patient satisfaction and quality and outcome. We set ourselves each year a stretched set of objectives which we develop in conjunction with our very active Council of Governors. So we have 2 roundtable sessions each year, one to think about the objectives and one to confirm them. So for the last year, we set a number of stretch targets, and what this series of slides does is talk through our achievement against those individual targets, flagging some of the areas where we could do better, but also identifying the level of achievement. So on the majority of our targets, we achieve what we set out to do. We've amber rated one on this screen, which is around some of the work we were doing to redesign the front door of the hospital, which we're continuing to do over this year. On the next slide, there's a red rated one, which relates to some system working on creating a shared care record, which I'm pleased to say is moving forward positively. We've also now signed the contract for a patient portal, which is amber rated on this screen. And also moving forward on the car park. You saw an artist's impression of it earlier. We've just put a planning application in for that, and we will be starting to build that over the course of this year. And then on the final screen, a number of green rated issues. I've not gone through each of those, but some really fantastic examples of some of the work we've been doing across the group here. So a combination of objectives that are specifically South Warwickshire Foundation Trust, but increasingly working collaboratively across the group. So the group spans Wyeth Valley Trust in Herefordshire and also George Eliot Trust in North Warwickshire. And what we've been able to demonstrate over the last couple of years is the way that our organisations have used that extra scale across the group to do even more than we would have done. And actually during COVID, we were actually able to join the clinical teams between those sites and to do innovative work around the way we set up critical care and respiratory services. And increasingly, we're advising others across the NHS on the establishment of group models and also doing some work nationally to demonstrate that group models are a way of achieving collaboration between providers. We'll talk a little bit about finance now. Within the report, there is a section which sets out in some detail our financial performance across the whole year. We continue to grow as an NHS, but obviously also as a local organisation. Just flagging one or two things on that slide. Firstly, our level of income, £337 million worth of income, a large organisation by any measure. And the majority of that income, as you can see on the right-hand side of that slide, is from our local commissioning CCGs, but also from specialised services, including our acquired brain injury rehab unit at Leamington Spa Hospital, income from local authorities for things like our health visiting and prevention services. From an overall performance perspective, we achieved a surplus of 9.77 million. That is unusual, certainly from Acute Trust. There's no other Acute Trust in the Midlands region who delivered a surplus last year. Because we created a surplus, we received a performance bonus. So £3.7 million of that 9.7 million surplus was what's called a Financial Recovery Fund performance bonus. And I'll show you the detailed accounts in a moment. Our capital spend, I've highlighted some projects there, £21.9 million worth of capital spend. And within that, also a cost improvement programme that delivered £8.1 million worth of efficiency in various projects across the organisation. So just turning to some of the financial statements, again, as I say, there's much more detail in the accounts if anyone wants to go through them. This is the statement of comprehensive income to any old accountants like me in the audience. We might call it the I&E account. The only thing just to draw out there is the adjustment for impairment. So our assets were revalued, which led to reduction in the asset value, which was adjusted for, and what delivers that 9.7 million overall result. And then statement of financial position, otherwise known as the balance sheet. Again, you can see that reduction in value there. Just to point out to those of you who like to look at liquidity, we ended the year with around £24 million worth of cash. as an organisation. Much of that has been accumulated over the past few years in achieving our bonus payment. And for this year, we set out an ambitious capital programme to spend that on improving services locally. There's a bit of a debate going on nationally about whether a foundation trust should have that freedom. We think we can demonstrate that the way we've incentivised our clinicians to be efficient, to invest in our services, proves the foundation trust model is an effective one. So we'll continue to use those freedoms to improve our services over the next few years. More important than the finance, though, for any NHS provider is how we perform from a quality perspective. Obviously, I've talked about the headline indicator, which is our assessment from the Care Quality Commission. But within our plan, we set out a number of quality priorities for this year, and they're reported in this summary report also. We link our strategy as an organisation to our annual corporate objectives, to our annual quality objectives, and those go down to individual directorates, departments, and individual objectives to ensure that we deliver. And on this slide, you can see a number of the crossovers from a quality perspective around some of the things I've already talked about, including our patient portal being developed, including improving our experience for some of our groups like patients with learning disabilities, which we're doing even more work on over this year. Again, on the next slide there, improving patient feedback, improving learning across the organisation, focusing on prevention. And one of the things I was most pleased with last year is around about January time, we produced across the group a booklet looking at the prevention initiatives that we're involved in. We don't have to do those things, but increasingly we see our role as an anchor organisation trying to improve the health and well-being of our populations. And many of our services have large prevention elements, particularly our out-of-hospital services. So finally, that's actually a photograph of the corner of my office, and it probably helps to demonstrate what's happened over the last few years. I put out a tweet in the height of the COVID pandemic to say, can I have something to cheer up my office? It sits on the corner of the site. A lot of staff drive or walk past the office in the morning. So we were inundated with lots of great rainbow pictures from children and adults actually across the patch, and it was great to see this. It was great to everyone who's joined us in this annual report from the community. It's great to have that support at that moment, but we've always had that support, and a lot of what we do as an organisation is dependent on our partners, whether they be in primary care, in social care, in our local authority more widely, our volunteers, our board of governors, our staff, but also their families. So one of the things I really enjoyed doing last year was writing to the children of a number of our staff to thank them for letting their parents work with us and supporting them throughout the COVID pandemic. Lots of letters were required because lots of staff wanted us to do that. It was great to get that feedback. So thank you to the families of our staff, particularly this year, and no doubt over the coming winter for what you do to keep the morale up of our staff, and for the sacrifices that you've made in order to maintain our local services throughout the last year. So I'm going to close down that screen, and hopefully we will get back.
Thank you, Glenn. And apologies, I'm picking up on some of the questions that some of you may be having problems with the sound or some of the technical aspects of the live event. So I apologise if that's affecting you. But just building on what Glenn said, one of the things that has been heartening, I know, for members of staff has been the community response to the challenges we've faced in COVID. And indeed, just another example is a lovely charity called Kissing It Better did some work with local schools on art and poetry. And our Director of Nursing, Fiona Burton, was involved in selecting some of the winners and celebrating some of the lovely art that was produced by some of the younger members of the community. So thank you very much for everything that's been done by people in Warwickshire to support the NHS at this time. So Glenn has obviously presented the annual report, quality report and summary accounts and auditor's statement, and they can now be formally received and noted. So thank you, Glenn. We'll therefore move on to the annual report of the Council of Governors. As well as being chairman of the Board of Directors, I'm also chairman of the Council of Governors, which is made up of publicly elected governors as well as stakeholder governors. And so this is their report from the 1st of April 2019 to the 31st of March 2020. The last annual meeting was held on the 8th of July 2019, as we've just received the annual report. At that time, the meeting also received a report on the Helping You to Help Yourself initiative and the Open project, and presentation, as we will do later, on the Going the Extra Mile awards to trust staff. Since that meeting, the Council of Governors has met formally 5 times, in May, July, September, November of 2019, and in February 2020. We would have met in July of 2020, but because of the COVID incident, we delayed that meeting, but we have had a meeting this afternoon. At each meeting, the Council of Governors received reports on the performance of the Trust and on Trust plans, and were able to question directors on these reports. The meetings also allowed the governors to seek assurance on particular areas that they were concerned about, and that happened throughout the year. As well as that, the subcommittees of the Council of Governors reported: the Nominations and Remuneration Committee, the General Purposes Committee, the Patient Care Committee, and the Business Oversight Committee. In performing its statutory duties during the year, the Council of Governors appointed Mary Malloy as the lead governor, and I'd like to put on record my thanks to Mary for her efforts on behalf of everyone at the Trust in terms of making the work of the Council of Governors effective. The Council of Governors approved amendments to the policy and procedure for non-executive director appointments, so that NEDs would be offered 2 3-year terms of office, and then subject to annual reappointment for a total of up to 9 years. They extended the chairman's contract until the 30th of September 2019. Then subsequently, following a positive appraisal report, extended my contract until the 30th of September 2020. They received and approved the recommendations from the Nominations and Remuneration Committee to reappoint 4 non-executive directors as follows: Rosemary Hyde until December 2020, Bruce Paxton until January 2021, Simon Page until February 2022, and Sue Whelan-Tracy until February 2022. They received and approved the report on the annual appraisal of the non-executive directors, as well as myself. They also agreed a process to recruitment of a new non-executive director to replace Angela Brady, who had left the Trust due to changes in her substantive work role. And at that point, I would encourage any members of the public who'd like to apply for a position as non-executive director. We are at the moment recruiting for a new non-executive director, and I'd encourage members of the public who believe they have the right competence and character to undertake the role to apply. They also received and noted the annual report of the Council for 2018-19. Highlights of the Council of Governors business included the Governors contributing to the Trust strategy and plans in the autumn and spring roundtable events with the directors. The Governors in particular sought assurance from the Trust during the year on its preparations for winter 2019-20 and the challenges of a growing local population, cancer performance and the impact of intelligent conveyancing. The Governors continue to contribute to a variety of internal projects, including end-of-life care, the Ellen Badger development, which Glenn mentioned earlier, the car parking, falls, and improving the patient experience project, which included the appointment and booking system. The Patient Care Committee continued to scrutinise the quality of patient care and received regular presentations from trust staff on topics of interest and received and discussed feedback raised by governors on behalf of their constituents. The Business Oversight Committee received reports from the Trust Audit Committee Chair and the Finance and Performance Committee Chair. The General Purposes Committee continued to oversee the arrangements for the conduct of business of the Council of Governors, and a Governor continued to be a member of the Clinical Governance Committee. The Membership Engagement and Government Involvement Strategy was approved at the Council of Governors meeting in February 2020. The strategy provided a more targeted approach to membership recruitment and engagement, focusing on groups who are currently underrepresented within the current trust membership, such as carers, working age people, and individuals from a BAME background. It also sought to use a variety of channels to engage with members, including more digital channels. During this time, membership recruitment has been maintained through inserts with outpatient letters, social media posts, special recruitment events, and the online application facility. And over the last year, I think all of the governors feel that the member engagement work has been a substantial improvement over previous years. Following a resignation, an election was held for a public governor for the West Stratford and Borders constituency area, and John Wright was duly elected. Elections were also held to fill the vacancy for a staff governor for the nursing and midwifery acute category, but unfortunately no nominations were received. So again, I'd encourage any member of staff who'd like to stand as a governor to apply, and that vacancy does still stand, and we will pursue it, but we do need a member of staff to apply. And then the final comment from the Council was, we, the Council of Governors, are assured that the Trust has again performed well. Led by our Chairman and Chief Executive, we expect this to continue. We are satisfied that despite challenging times, the care provided by the Trust has been of a good standard during the last year. We are also assured that its finances are well managed by a competent management team. We are pleased to have seen a number of significant developments which further support patient care. We see our role as holding directors to account, seeking assurance on behalf of our members, and supporting the Trust in ensuring the current position continues, and where possible is improved. In the coming year, despite continued and increasing pressures and challenges facing the NHS nationally and locally, we are confident. So that concludes the annual report of the Council of Governors for 2019-20. And as Chairman of the Council, I would like to thank again the enormous amount of work and effort that our governors put into helping the Trust improve and to represent the population's interests. So thank you very much. So I can confirm that the annual report of the Council of Governors can be formally received and noted. We'll therefore move on to any other business and to seek any other items of business from Council of Governors or board members via the Q&A function. And none of those have been forthcoming, so thank you. So I think at that stage, I can close the formal meeting and inform you that the next date of next year's meeting will be arranged in due course and advertised appropriately. So thank you. So with the close of the formal meeting, we can now move on to the presentation part of this annual general meeting. And I'm delighted to welcome Duncan Vernon, who is our consultant in public health. Members of the public will be aware the heart of the strategy for SWFT is helping you to help yourself. It's a desire to help our population live longer, happier, healthier lives. And we were delighted this year to appoint Duncan into the role with our colleagues to be our consultant in public health. So Duncan, over to you.
Many thanks for the introduction, and I'm hoping that you can see my screen. So as introduced, my name's Duncan Vernon, consultant in public health, and I started the post just under a year ago. So the presentation I'm going to give today is about public health and prevention, and in talking through that, I thought it's probably worth talking about first, well, what is public health and what do I mean by that? And I thought I'd start here. Before I go on to the technical definition, I was going to start with just a bit of my perspective, and that public health is about the health of the whole population. So in hospitals, we might diagnose ill health and decide on the best course of treatment for a patient. A population health perspective is diagnosing and deciding the best course of treatment or action for a whole population, for groups of people. So thinking, you know, there might be a patient with CVD, but a population health question is asking, well, why are there so many patients with CVD? Are there more or less than you might anticipate for a similar area? How is that distributed through Warwickshire? Which groups of patients are more likely and more at risk of that? And when you start to understand that by taking a population health perspective, you start to be able to do something about how to prevent it. And so whenever we're asking questions about groups of patients or more larger populations, that's when we're asking a public health and a population health question. To go into the definition, and I'm going to break it down because there's three different bits to this, I feel. The first is, you know, improving population health and in public health is an art and a science. So yes, public health relies on a lot of scientific perspectives. It relies on the epidemiology, it relies on behavioural science, it relies on health economics and qualitative methods to understand how people are feeling. But then the art of it is how you use that to advocate for actions to improve health. Public health is about three aims here. It's about preventing disease, and we've talked about the increasing demands on the NHS earlier, and of course, by preventing disease, we hope and anticipate we have an impact on those demands. It's about prolonging life, so not just about prevention, but pound for pound, how do we get more value out of health services? What can we do to improve the quality and use the evidence base to understand the impact that we're having? And finally, it's about promoting health. And health, for me, isn't just the absence of a disease. It's a much broader and a much more positive thing. It's about a good state of mental and physical well-being, and it's about having the capacity to do things and live a good life. And that's the importance of sort of health, and it's defined as something unique and on its own. And finally, it's about the organised efforts of society. So this brings us back to that population health question. It's about a population endeavour, and it's about something that we do collectively. And in this presentation, I'm going to talk about Warwickshire's shared endeavour. It's hard to talk about health in Warwickshire without talking about coronavirus, of course. And this is what I would call an epidemic curve. It gives you the day by day in the life of Warwickshire over the last year, starting in the first case that we had towards the end of February and all the way up to the worrying increase in numbers that we're seeing nationally and in part reflected in Warwickshire as well. When you look at this, you remind yourselves of the journey that we've been on, and actually through March, we saw numbers increasing up until that early peak where we had sort of numbers were highest in hospitals. And then through April, we saw numbers increase because community testing was sort of, there was more access to that, more people were able to get access, and we started to get a truer picture and a truer understanding of the impact of coronavirus and the amount that it had spread in our communities. But I think we started to understand more, and it's shone a light on some of the health inequalities and some of the fundamental health challenges that we have, not just in England, but in Warwickshire overall. And it's quantified them in such a stark way. We've seen this in other infectious diseases, of course, you know, so things such as TB and bloodborne viruses such as hepatitis B and C, we've always seen impacting on the most vulnerable. But here, coronavirus has also brought some of these things out. I mean, I realise if we reflect on who's impacted by coronavirus, we talk about the elderly, we talk about people with underpinning health conditions, and of course the risks that our health and social care staff and members of and people working in the trust had put themselves in working with patients. But when we dig deeper, we start to see other trends emerging as well. We start to see mortality rates from COVID in the most deprived areas would double those of the least deprived. And that's not just because of greater levels of infection, it was also because of the increased risk of dying from that infection. We saw people from ethnic groups such as who would identify or be classified as black ethnic groups more likely to be diagnosed, and again higher death rates. And we saw other professions as well at higher risk, and everyone else who sort of has face-to-face or working in enclosed environments, we saw higher risks, such as butcher and coast drivers or sort of construction workers, for example. When we start to sort of understand that and dig down into a bit more, we start to see the role of other health issues coming out. So I mentioned the higher risk of death in more deprived areas, and we also see on the death certificates greater levels of mentions of things such as hypertension or diabetes, and showing how those long-term conditions have impacted on the harm from the virus. As public health teams have investigated the virus and done work contact tracing and sort of trying to prevent the spread, it's uncovered issues around modern slavery and precarious living conditions and insecure employment. And all of these things are reminders that actually a virus doesn't just exist on its own. And we've had frequent reminders of this through various reports, starting from the Black Report in the 1980s that talked about health inequalities, all the way through to the Marmot Review, Fair Society and Healthy Lives in 2010. And I hope the pandemic will be another reminder that inequalities can be addressed and exist. So to try and quantify some of this, and this is about health inequalities before the pandemic, we saw this is a graph from a useful study in one of the Lancet journals where the co-author was Michael Marmot, who wrote that report. And it looks at deaths under the age of 75. Right, so what's going on here? So what the research team did is essentially they divided the population up by deprivation into 10 equally sized groups, from the least deprived to the most deprived. And then we counted the number of deaths under the age of 75 in all of those groups. And you can see up the side the thousands of deaths that had happened between 2003 and 2018. And you can see the difference between the least and most deprived areas in terms of those early deaths. So from the least deprived areas, it was around 175,000. In the most deprived, it was double that at around 350,000. If everyone had the same risk profile as the most affluent, there would have been 900,000 fewer deaths over that time period under the age of 75. That's one death every 10 minutes. That's a significant number. And the other thing to highlight here is it's not just about extreme poverty. As you can see, it's a series of steps between each of these groups. And I think that tells us and reminds us that inequality is something that affects everyone in society. If you're doing moderately well off, if you're in the middle of that, you're still at higher risk than the most affluent. And I think that makes the health inequalities agenda really important for us to understand and to deal with in places where you wouldn't necessarily expect higher levels of deprivation. And then in terms of what that means for the NHS, I mean, taking the same approach, what if everyone had the same level of risk as the most affluent? What would we have seen? And, you know, talking about some of the conditions that we see and treat in hospitals, you know, we would have seen if everyone had that same level of risk as the most affluent, 50% less heart disease and 40% less stroke. There's other issues here that you can see where there's more extreme inequality, such as COPD. And if I was to unpack that cancer statistic, you'd also see how lung cancer is incredibly unequally distributed. And when you look into it a bit further, you start to see that how the differences in smoking rates influence that. And again, the importance of helping people to help themselves to give up smoking. So let's bring this back to Warwickshire and look at some of the inequalities in Warwickshire. I'm going to talk through this slide in two halves. And firstly, let's focus on the left-hand side. So life expectancy for men in Warwickshire. And life expectancy is the average age at which you'd expect to live from birth. In Warwickshire, it's 79 years, but again, looking across the most affluent and most deprived areas, and sort of by most deprived, again, there's areas in South Warwickshire that fall into this category, is that difference between 85 and 74, so that's an 11-year difference. When we look at healthy life expectancy, so the average age at which you'd expect to live in good health, the average for Warwickshire is 64 years, and again, you see an 18-year difference between the most affluent and most deprived. There's a few things, I'd highlight from this. So firstly, if the pandemic hasn't shown, that close relationship between health and wealth, that a healthy population is an economically active one, this underlines it. If in some areas the average person is unhealthy before retirement age, that's going to have an impact on our economy. And secondly, I think it shows that by improving conditions, you're not just moving ill health to the end of life, you're actually narrowing the amount of years spent in poor health. So actually by doing prevention, it's not just shifting the problem, you're actually doing something to reduce that window of need when services are needed. So what are those things that we can do to improve conditions? And you'll remember how when I talked about the different, how each of those conditions was impacted by inequalities, and you'll remember that it was something that was cross-cutting across a range of conditions. So this isn't about sort of a new set of condition-specific pathways, and it's not just about the health services, it's about how we all collectively work together. There are other issues that influence health and well-being, such as what I would call the wider determinants of health. These are the causes of ill health, and it's things such as income and wealth and the importance of a good job and how we travel about and good quality housing. It's our health behaviours and lifestyles, so things such as smoking, diet and exercise, the amount that we drink. And it's about the importance of the local environment and the connections between each other. And we know, for example, that good mental health is your mental health is improved by having social contacts and social connections and being parts of groups. But then that has an impact on your physical health and your risk of hospitalisation. Some of the evidence on social isolation and loneliness in the elderly really shows that actually by addressing it, you can reduce hospital admissions. And I think the more we understand and are able to respond to this bigger picture through all of those patient contacts that we have, the more we're able to see those connections between the patients in front of us and our healthcare services and the environments and lifestyles that have influenced how that patient's ended up at the hospital door, the more we can understand about what we can do about it, and the more we understand the risks of discharging patients back into the environment that made them ill and what we can do to support them to stay in the community. So I brought a couple of facts about Warwickshire and just to sort of give you an example of some of these issues that we see. So again, in Warwickshire, around 72% of children achieve a good level of development by the end of reception, and I've talked about the importance of a good start in life and how that impacts on your health in later years. And again, we sort of mentioned earlier, the role that SWFT services are playing here in terms of the health visiting services, and especially when they are working with younger parents and parents from more deprived areas in order to give those children a good start in life. Issues around the difference in employment rates between those with learning disabilities and the population overall. Good health is, a good job underpins good health, and again it's highlighted by some of the recent thinking around NHS England, where they're sort of talking about this gap and again what health services can do. And around 600 households are either sort of in temporary accommodation or sort of homeless people, and not in priority need is a housing term, but this is typically refers to sort of single men, possibly with sort of mental health or substance misuse conditions, which are a cause and a consequence of becoming homelessness. And again, SWFT services have worked here in terms of two of our out of hospital nurses who have been working closely with this vulnerable and homeless population throughout the pandemic. Health behaviours and childhood obesity does remain a significant public health issue, and it's one that's unavoidable when we're thinking about poor health in the population. And again, it's one that's distributed unevenly, so you're more likely to be overweight or obese if you come from one of the more deprived areas in Warwickshire. And again, here thinking about the role of some of the school nursing services in our neighbouring local authorities that SWFT run, as well as the health visitors. 13.3% of adults smoke, and the long-term plan has aspirations around this, and I'm really looking forward to seeing what we can do in the trust in order to implement and do more around stop smoking off the back of that. And again, physical activity being quite important, and I had a couple of really good conversations when we were talking earlier this year about how to make a more active hospital and how things such as the work in wards to end PJ paralysis and make patients feel less like their patients and become more active, and some of the events coordinated on wards to support patients becoming more active. And again, going back to sort of how we support patients to connect in with some of the sort of exercise or sporting groups in the community. And finally, on communities, again, we highlight some significant issues such as the lack of social contact that adult carers have. Warwickshire was always historically high in terms of numbers of suicides. And again, understanding the epidemiology, for example, it's one of the leading causes of death for new mothers after discharge from hospital. And again, looking at the role of the SWFT midwives in sort of supporting the parents and the psychology of new parents. And then some things that I can't measure, but which are important, and you know, around volunteering and peer support, and the role of the third sector in providing good health in communities. So how has COVID-19 impacted on all of this? And again, it's the thing that's impossible to get away from this year, and it has had a deep impact across all four quadrants of that model that I talked through earlier. We've seen increases in unemployment and potentially more to come. We've seen changes in health behaviours across the population, quite significant shifts, and of course the impact of social isolation and loneliness, particularly on people who are shielding. So in order to address that, any recovery from coronavirus can't just be from the NHS. We have to work with other organisations, and we have to understand the role that each of us can play in improving the health of patients and the rest of people in our communities. And the wider impacts of the pandemic are more likely to fall on those same communities most directly impacted by the disease. So people in precarious employment, people from more deprived areas, for example, more likely to become unemployed as a result of COVID. So there's a double impact on some of our communities that we need to be aware of and need to think through how we address. Some examples, you know, so we've seen where people have increased their risky alcohol use, but of course some people have given up altogether, and how do we support those people to maintain that? The pandemic's impacted on mental health, and every other adult has reported poor mental well-being as a direct result of the pandemic during lockdown. And again, shifts in the way that people gamble and all of these things that impact on poor health. So what can we do? And I'm often asked sort of what are the big things that, you know, I can do as an individual, and you know, I think I try not to do that finger wagging consultant in public health thing, and try to sort of encourage reflection. I think when I've run behavioural change programmes, this is what, you know, can be quite important in sort of people coming to their own conclusions about their health and having understanding some of those causes. The last 6 months have had a huge impact on all of us, and it's about, I guess, reflecting on what some of those positive changes to lifestyles have been and thinking about how to keep it. And then thinking about some of the things that kept us healthy before the pandemic and what we can do to get them back. And again, you know, thinking about what services or our friends and people around us might help us to help ourselves to do that. And then that leads us on to a second reflection, though. If we're thinking about our own health and the impact on us, which is quite, you know, apparent how things have changed, you know, we can start to think about what's impacted on our patients as well, and some of those connections. I've highlighted some of the impact of the pandemic here, and I've highlighted some of the big issues that we see in Warwickshire. And I think, you know, it's important to note that healthcare systems do and can contribute towards good health. I've highlighted some of the role of SWFT services that we're already doing, but there's probably, well, there are more opportunities out there to improve health, as well as curing and preventing illness. So it's about sort of understanding, taking that population perspective, thinking through, you know, out of all of the patients that come to us, what are the commonalities, what are the other things going on in their lives, and what can we do to connect with other organisations to help make them healthy and help to give them more control over their own health. And it involves us working outside of traditional roles. But there are the opportunities there in terms of when we recover, and that's how healthcare services can start to influence and have a bigger role on health when we start to understand what all those connections are in the bigger picture. And I think there's some big opportunities here that we can work on at SWFT.
Duncan, thank you very much. As ever, a very interesting presentation. And as an anchor institution in Warwickshire, we obviously do take very seriously our obligations to help with health inequalities, both amongst the communities we serve as well as with our own staff. For members of the public who might be interested, there is a really great book by a lady called Camilla Cavendish called Extended Time, which are a series of sort of public health observations from around the world about how we can all live longer, happier, healthier lives. But part of the challenge, and it goes to the heart of our strategy of helping you to help yourself, is I was born in 1960, and since 1960, on average in the UK, we consume 35% more calories every day. And we burn 25% less calories because we lead more sedentary lives. And as a result, just by way of example, obesity amongst men has gone from under 1% in 1960 to about 30% now. So the challenges that Duncan sort of referred to are very real, very complex. We absolutely will play our part as an anchor institution, but we do need members of the public to work with us and to listen to the messages that Duncan and his colleagues are increasingly helping to form. So thank you, Duncan. I will now move on to the SWFT journey through COVID-19 video, which has been produced here. Glenn, over to you.
So I think we're going to get this lined up and ready to go. I can see it on the screen.
In my almost 37 years working in the NHS, these last few months have been the most challenging, but also they've been the most innovative in the whole of that period. And they've also provided great opportunity for our staff to demonstrate their caring attitude and the way they're up to absolutely every challenge that they face. So you're going to see in a moment some fine examples of that. Doesn't cover everything, but hopefully you enjoy what you see. Really proud of the teams that we have across the Trust. And really pleased to see all of the work they've done over the last few months, and no doubt the efforts that we'll continue to put in over the winter. Thanks to all of them. Hope you enjoy the video.
My role during the pandemic, which isn't over yet, is to advise the organisation on all the steps that we need to take from an infection prevention point of view to reduce infection risks, particularly around COVID, to all our staff and service users. That makes it sound really simple, but keeping on top of ever-changing guidance, understanding this very huge new global viral threat has been really quite a significant challenge.
So my role within the pandemic was to be part of the swabbing team, and I would be on shift with two other people. One person would be the person who physically swabbed. The other role would be the person that received that swab stick and popped it into the bag ready for pathology, and there was also an admin role who would make sure all the personal details were available.
During this pandemic, I've been sitting on Silver Command and working with lots of groups to provide advice to the leadership team throughout, and predominantly my first concern was oxygen capacity across the Trust and flow throughout the Trust to ensure that we had the amount of oxygen flowing to the wards if needed, if we had to escalate the number of patients we required for a surge. Following that, it was to help advise the estates team on ventilation requirements.
Our role was to try to find alternative ways of delivering a service to our families throughout the footprint, and to also support staff in working from home and finding alternative ways of communicating within their teams.
During the pandemic, I continued in my clinical role, so I worked at the front door seeing and assessing patients with suspected and confirmed COVID, and I used that clinical role to work with all of the teams who were involved with COVID patients to establish some consistent pathways for how we were identifying, diagnosing and managing those patients and how we managed their flow through the hospital. I was also part of the infection prevention team, again giving some clinical input and helping implement all of the infection prevention policies to do with COVID.
Firstly, communication. We updated each other, we learnt from each other, we talked very openly to each other, and we pulled together as a whole team within the organisation to address the challenges COVID was presenting for us.
The speech and language therapist kind of put together a bit of procedure which we were given some vague guidelines for, and we very much tailored them for swabbing staff to begin with, so it was very vigorous. with our kind of PPE, with our hand washing, and then as the criteria changed a little to swabbing staff and patients, as we were now swabbing all patients due to have a procedure in hospital, the goals and the kind of guidelines changed a little, so we had to do lots of problem solving as we went along. What also worked well was that our